Hello, everyone, and welcome back to Karan Academy. My name is Karan, and today we're going to be starting off our endocrinology series with diabetes. Now, diabetes, in my opinion, is one of the most important, hardest, and most content-filled topics for your matrix this year. It has a lot of aspects to it, particularly some things that you should know and should be very comfortable with is knowing what is diabetes and being able to explain this to a patient, the difference between type 1 and type 2 and how you can clinically, as well as on investigations, tell the difference between the two, the tests used, as well as specific cutoff values, complications for diabetes, both the microscopic and the microvascular and macrovascular complications, the different therapies available, as well as the specific medications used to treat diabetes, and that extends to their side effects, their indications, when can we use them, when can't we use them, when is each one favorable, and so on. So there's a lot of content to get through, but I think a lot of it does make sense. And I know I keep saying that, but let me know if you have any questions by the end of this video. Cool. So what is diabetes? Basically, diabetes just means too much glucose. And the term diabetes comes from too much sugar in the urine. And that's how it was originally picked up and found that there might be something going on. So it's an imbalance with insulin production, resistance, and metabolic syndrome. So that has multiple elements. I'm sure you've heard of type 1 and type 2 diabetes before. So just going over this once again. With type 1 diabetes, you have an autoimmune process that causes destruction of the pancreatic beta cells. Now, the pancreatic beta cells are responsible for producing insulin. If you lose them, you're going to have absolute insulin deficiency. What this means is you just aren't producing insulin. If you don't produce insulin, you are going to end up with hyperglycemia, because whenever you do eat food, you're not going to be able to move that glucose from the blood into the cells, because that's what insulin does. And this is typically seen in younger patients. And the primary management is just focused around supplementing insulin and providing them the insulin exogenously if they can't produce it. Now, there's a non-classical type called latent autoimmune diabetes of adults called LADA, and it's relatively rare. About 5 to 10% if diabetics have LADA. And what it basically is, it's the same picture, except it presents in adults. The reason for this happening, or what they suspect, is that patients with LADA have the same kind of genetic predispositions and risk factors. However, the trigger for that onset is often present in adulthood and doesn't happen till that stage. So when I say trigger, the typical story you get with a type 1 diabetic is that they were fine and then they got sick. They went on something that stressed their body out of the usual, and then they started kind of going downhill. And it's a combination of that genetic predisposition and environmental factors. Next, we have type 2, which is the most commonly seen type of diabetes in the community. It's caused by insulin resistance that's linked with metabolic syndrome. Now, metabolic syndrome is a very complex condition. We talk about it later, and it refers to a combination of hyperlipidemia, insulin resistance, obesity, blood pressure issues. So it's quite a complex disease of the modern world. And as you probably know, it typically affects older patients. But much like with LADA, we have an unorthodox subtype, and that's called MODY, or maturity onset diabetes of the young. And it works on the exact same principle, that they just have a higher genetic predisposition for developing that resistance earlier on. Next, we have type 3 diabetes, and this is probably something that might be new to you. So this is things that cause issues with insulin production that aren't either a resistance or an absolute deficiency. So pancreatic cancer, pancreatitis, hemochromatosis, acromegaly, Cushing's syndrome, all cause hyperglycemia. So the first two cause hyperglycemia by interfering with insulin production and secretion, both on a microscopic level as well as structurally. Hemochromatosis, because in the liver, when you have a higher rate of turnover, you're actually pumping out more glucose, and this can lead to hyperglycemia. With acromegaly, you have excessive growth hormone, and that again affects the liver to produce to release a lot of glucose in the blood, causing hyperglycemia. And same thing with Cushing syndrome. And next you have type 4 diabetes or gestational diabetes. And this quite typically it only happens in women. It starts and ends with pregnancy. So usually if it's just gestational diabetes, it has a good prognosis. It's something that I don't want to go into the depths of explaining why it happens, but it's a combination of placental insufficiency, genetic predispositions, as well as other metabolic syndrome-like factors. But usually when they give birth, we see a rapid return to normal, but some cases do tend to, about 1/3 of them do tend to go on and progress to full-blown diabetes. And that's usually type 2 diabetes. And it's obviously linked to maternal and fetal complications. So here's a table which is summarizing the key differences between type 1 and type 2, and you absolutely need to know this. So we talked about what the main cause is, and in terms of age of onset, you know type 1 is going to be earlier than type 2. The insulin levels are low in type 1, makes sense, but in type 2, you can see a fluctuation. So what happens is, in earlier stages, when you have that early on insulin resistance, your pancreas tries to compensate for that by producing more insulin. And usually it works out well until it no longer can do this, and then it crashes. So you overwhelm the pancreas and then it crashes. So typically we see slightly higher levels before progressing on to lower levels. The risk of DKA or diabetic ketoacidosis is quite high with type 1, and that's very commonly how they first present to hospital. It starts off with vague symptoms, headaches, tummy pains, not eating as much, peeing too much, and then they deteriorate very rapidly. That puts them into hospital. Now, DKA itself is quite rare in type 2 diabetes, and I'll just go through why. But one phenomenon that's quite common is this thing called hyperosmolar hyperglycemic state. It is very similar to DKA. It is, they again can present with altered mental state, but instead of it being because of ketones, it is just because of very high levels of glucose in the bloodstream. Now, you may be asking, well, Karan, why can't you get DKA in type 2? Well, that goes back to our principle of why do you get DKA in the first place? So with type 1, you have no insulin, right? And that no insulin means you're not going to be, at its worst, you're not going to be getting any glucose into your cells. When you have no glucose, your body has no alternative but to switch to using fats and using its breakdown product, ketones, for energy, because ketones can't cross the blood-brain barrier. It is also why it presents with altered mental state, right? So you get DKA because you have absolutely run out of glucose 100%. With type 2, although you may have very high levels of blood glucose, you're almost never going to have a situation where your cells have no access to them. It will be very low, which is why you can present with HHS, but your body and your pancreas is still going to be secreting insulin, and as much resistance as you may have, there's still some insulin that's going to be, there's still some glucose that's going to be going into your cells. Because of this small amount of glucose is not going to be sufficient to sustain most processes, but is going to be enough to put off the use of fats and ketones, which is why you don't get DKA with type 2 typically. The C-peptide is another really good test that can be used, and we talk about the C-peptide later, but it's actually, I'll just talk about it here because we're talking about it here. So what is the C-peptide? If you go back to your endocrinology lectures and look into how insulin is produced, you have this additional protein called the C-peptide that is cleaved off during the production of insulin and doesn't really serve any major purpose, but is kind of an indicator of the production of insulin in your body. We don't really test insulin levels themselves, but we can test C-peptide levels. Now you may be asking, Karan, why don't we just test insulin levels instead? Seems easier. I would agree. Seems easier, yes. However, insulin levels fluctuate a lot across the course of the day and depend a lot on when you've had food, what have you had. C-peptide levels stay relatively, are a bit more stable to monitor. And as you can imagine, with type 1 diabetes, because you're not producing insulin, you're not going to be, or you're going to have lower levels of C-peptide. And again, with type 2, you may have higher or lower levels. In terms of the presentation, I already talked about how type 1 is usually going to be more acute, typically with DKA, while type 2 is going to be more chronic, asymptomatic, and they can often present with the microvascular and macrovascular complications. In terms of an autoimmune association, type 1 diabetes is very important to know, specifically conditions like celiac disease and thyroid abnormalities, so Hashimoto's and Graves, while it's uncommon in type 2. However, type 2 has a huge family history. Some could say greater than type 1. And this is something that confused me in year 3 because I associate autoimmune associations with family history, but they're not quite the case here. So moving on, how can you diagnose diabetes? Well, you start off with your typical history and exam. There are a few situations where you'd be asked to do or undertake a diabetes history, and these are the situations. So an asymptomatic patient we are just screening for, patients who have symptoms of diabetes, emergency cases, patients with diagnosed disease coming in for reviews, and gestational diabetes. And the most common ones the most common ones I'd expect you to be asked at this level would be 2, 3, and 4. Gestational diabetes is obviously not part of your curriculum at this moment, and asymptomatic patients unlikely you're going to be asked. So you need to know these 3 really well. So how should you split your history? So my recommendation would be start off with your normal history of presenting complaint, ask about go through your WWQQA, which is kind of your what, where, quantity, quality, associated, alleviated factors, all that. Ask about family history, drugs, past medical history, diabetes specific questions if they haven't been diagnosed yet, and we'll go through what they are. After that, you want to assess the progression of their diabetes. So when were they diagnosed, how good the control has been, especially if you've been their GP, their recent blood work, and then ask how their diabetes is being controlled, assess for complications, and ask what they are doing to better improve their health, and then talk about future management, control measures, as well as pharmacological interventions. And this would obviously relate very closely to their disease status. So what symptoms do we ask? So I mentioned symptoms. So based on age and demographic, I think the first thing you need to ask yourself is, and presentation is this going to be type 1 more so or type 2? If you can't make that association, that's fine. But in most cases, you would have a rough idea as to what you're expecting. Things that are common to both and happen because of high levels of blood glucose, which you see in both, would be polyuria, polydipsia, and polyphagia. Polyuria, because you have high levels of glucose, that's going to be pulling in water into the renal tubules, and you're going to be having, and you're going to be peeing a lot. Because of that hyperosmolar state in your blood as well as the polyuria, you're going to be drinking a lot. And polyphagia, partly the same principle as polydipsia, but also because your body has increased metabolic demands, not because you aren't eating, it's just because that glucose is not getting into your cells. All that has to do with hyperglycemia and hyperosmolarity, which obviously would happen in both type 1 and type 2 diabetes. Next, moving on to specific stuff for type 1 diabetes. The most common presentation, as I said, is again DKA. So you want to ask about things like fruity smelling breath, called a ketotic breath or a ketone breath, abdominal pain, which is typical of DKA, nausea, vomiting, blurry vision, weight loss, and dry skin. Dry skin because of dehydration, weight loss partly because they'd be dehydrated, and also because you can't have glucose going into your cells. You would be using your fats, and that can often lead to weight loss. With type 2 diabetes, you really important to do a cardiovascular risk assessment. And assess for assess their risk for cardiovascular disease and treat their metabolic syndrome or hyperlipidemia or hypertension. And then assess for microvascular complications, which are your three main ones. So you have retinopathy, nephropathy, neuropathy, and we'll talk about how you'd ask for that. And then you have your macrovascular complications like peripheral vascular disease, cerebrovascular incidents, and coronary vascular disease. So now going on to their diabetes control and progression. So a few questions that you could ask: how are they going with their lifestyle SNAP-W? So SNAP-W is a really good acronym for lifestyle changes and recommendations. It stands for smoking, nutrition, alcohol, physical activity, and weight. So those are all areas you would like to stress on. Are they regularly measuring their blood sugar levels? This would be even more important if someone's on insulin therapy. What are their normal readings? What's the highest and lowest they get? And it's really good to ask if they have a BSL diary, which would be which they can just hand to you and you can have a look at. How often do they have hypos? And this is really important when we consider their pharmacological therapy. Now, hypos can lead to quite a few complications. So the therapy we give them, it's a very fine line of making sure their blood sugar is low to the point that they don't have complications, but also not too low that they end up having hypos. And then what was their last HbA1c? Because that's going to guide our therapy. Now let's talk about the complications that I addressed earlier. So with microvascular complications, retinopathy, have they had any issues with vision? And last time they had their eyes checked. Nephropathy, changes to urine. They'd be leaking protein typically with diabetic nephropathy. So ask if it's frothy. Ask for BP control as well as UTI screens. Now, UTI screens is important because as you start peeing out more glucose, that is a very nutrient-rich medium for the growth of bacteria. So UTIs are important to screen for. Neuropathy, so autonomic issues, so pee, poo, and erectile dysfunction is how I think about it. So issues with urine, so bladder, so urinary incontinence and urinary retention, fecal incontinence and erectile dysfunction are all very important to ask for. You can also ask for things like orthostatic hypotension and check for it as well. And finally, in terms of sensory changes, ask about loss of sensation, pain, if they feel particularly cold in the limbs, and diabetic neuropathy typically presents in a glove and stocking fashion, affecting the peripheries first. Next, with macrovascular complications, you have PVD or peripheral vascular disease, which we've already covered in our lecture series on cardiology. But ask about cold peripheries, things like intermittent claudication, paresthesia, anesthesia. Ask about cerebrovascular incidents, which is basically strokes. So have they had strokes in the past? And if they do present with any neurological changes, you want to have a very thorough history on the sensory, motor, or visual changes that they have been experiencing. With coronary vascular disease, you want to ask about a history of AMI or CCF, or congestive cardiac failure. The reason you ask for CCF is because a lot of patients who have AMI and have coronary vascular disease tend to end up developing CCF, so it's important to screen for. So chest pain, shortness of breath, palpitations, and then with CCF specifically, we've again talked about it earlier, but break it down into your left versus right, if that's easier to think about. So ascites, swelling of the lower limbs, breathlessness, and all that. So now talking about diagnostic thresholds. So we can either do a BSL, which is fasting or random, or an oral glucose tolerance test, which is the gold standard. In terms of making a diagnosis, you either need two test findings. So that can be a BSL. So you need two BSLs to diagnose diabetes if they're asymptomatic. You need two HbA1cs to diagnose diabetes if they're asymptomatic. You need one oral glucose tolerance test to diagnose diabetes, regardless of their situation. However, if they have symptoms typical of diabetes, that number for BSLs and HbA1cs drops from 2 to 1. What I mean by this is, if you have, let's say, a 55-year-old male who you think might be on the risk of developing diabetes, but has no symptoms and completely fine, you do a BSL that comes back at, you do a fasting BSL, let's say that comes back at 8. Well, you know that that's within the diabetic threshold. You can't say it's diabetes just yet. You need to do another one, typically in a few weeks. And you could use this opportunity to stress that lifestyle change. And if it comes back high again, then you can say that the patient has diabetes. However, if the patient came in with polyuria, polyphagia, polydipsia, some sensory changes in frothy urine, and had a fasting BSL of 8, that is enough to say that the patient has diabetes. In terms of normal pre-diabetic and diabetic values, I would highly, highly recommend memorizing this table. So fasting ones are very, very important to know. So less than 5.5 is normal, 5.5 to 6.9 is pre-diabetic. And it is at this stage, if you get somewhere in between this, is when you'd consider doing an OGTT. Above 7 falls within the diabetic level. With random levels, the normal for random blood glucose is still 5.5 to 11. The reason it's 5.5 is that normally it can be less than 5.5. Obviously, random just means it's taken at any point of day, any time of day. And normal patients, if they were fasting, they would have a level less than 5.5, right? And that is the same with a random level. So with randoms, we don't really look at 5.5 or any of this stuff. All we say is that if the level exceeds 11, it is within the diabetic level. What I mean by this is, because this is a random test, all we are saying is what's the absolute max that their blood glucose could hit. So what I'm trying to get at by this is, at no point of day should your blood glucose level exceed 11. If we are unsure, we can do an OGTT. So what this involves is getting them to fast since the night before. In the morning, you take their BSL and you give them a sugary drink, which contains 75 grams of glucose. And then after 2 hours, you measure their blood sugar level again. And that would tell us whether they are in the normal, pre-diabetic, or diabetic range. You can also do an HbA1c. An HbA1c is a really good test, particularly because it looks at a longer period of time. So as you know, your red blood cells have a turnover of 120 days, or about 3 months. And the HbA1c is kind of a representation of the glycemic control over those 3 months. It is also the reason why you don't do an HbA1c more than once every 3 months, because it would serve no purpose, because you're looking at the same red blood cells. And here's basically a graphical representation taken from Ben Amberg's resources, who's absolutely fantastic. I'm sure most of you guys would be aware of him. That basically summarizes the findings. So some extra tests you can consider. If you're unsure about type 1 versus type 2, you can check C-peptide levels, and we've talked about this. Urinary ketones and venous blood gas is really useful if you're suspecting DKA. And I've already talked about arterial versus venous blood gases in the past. Venous blood gases are perfect for looking at acid-base and electrolyte imbalances. Arterial blood gases are perfect for looking at oxygenation status. You can also do a urine dipstick looking for ketones, glucose, leukocytes, and nitrates. So the first two relate to their diabetic control, or well, ketones would refer to mostly looking for DKA. Glycosuria can be seen in either type 1, type 2. Leukocytes and nitrites looking for infections. A serum fructose amine level is sometimes used as a replacement for HbA1c levels in pregnancy. I won't go through this a lot, but you don't really use HbA1c in pregnancy because you have a much higher rate of RBC turnovers, and it can be quite unreliable. You can also do a few other tests at the time of diagnosis. So FBE, looking for anemias, which you can potentially correct. UEC is checking for renal function damage, if there is any, and electrolyte imbalances. LFTs, because as you mentioned, a lot of the type 3 diabetic causes can have an association with hepatic issues. And also with metabolic syndrome, you want to ensure that they don't have some form of hepatic impairment. Also, I keep adding points. Also, some medications are hepatotoxic, so you want to consider that as well. You can do something called an albumin to creatinine ratio, which is an excellent test for the kidneys and can pick up microvascular damage or diabetic nephropathy about 2 years before you would transition to CKD. So the way you could explain this to your patient is, well, if you have a high level now, it doesn't really mean that you have chronic kidney disease at this point in time. What it means is that your kidneys are leaking out a bit more protein than what we'd like. And it indicates that if we don't address this adequately, you could progress on to CKDs. That's kind of a good spiel with a hopeful twist as well. And anything greater than 3 milligrams per millimole is considered positive. Regular blood pressure monitoring also really, really important from both the diabetic high metabolic syndrome perspective, as well as from their kidney perspective. If you suspect type 1 diabetes, you can consider autoantibodies. So you want to do them both for the diabetic side of things. But if they do have diagnosed type 1 diabetes, you can also use that opportunity to screen for celiac disease as well as thyroid conditions. The 3 important type 1 diabetic antibodies you should be aware of are the glutamic acid decarboxylase, or the GAD antibody, the insulinoma antigen 2, or the IA2, and the islet cell antibody. So how do you treat diabetes? The first and most important thing that I cannot stress enough is please, 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 please push lifestyle changes as much as possible. And that includes your SNAP-W, so smoking, nutrition, alcohol, physical activity, weight loss. And the way you can explain it to your patient is that, look, we are in this situation and there's not much we can do to reverse this with just medications. We can obviously help. However, you need, the way I've seen my GP explain it to patients during meditation was that he is willing to do absolutely everything it takes to improve their diabetes. However, their patients need to be as involved and be willing to make positive changes in their life to help them. So it's kind of putting certain responsibility on the patient as well to keep them accountable. And I think that's reasonable. You want to talk about cardiovascular risk assessment and lipid control, their lipid levels, blood pressure control, as well as regular monitoring. Tell them the complications to look out for. So I know in your head you are already well aware of the complications, but just let them know what some red flag complications are and presentations that they should go to the hospital if they do have any. So if they suddenly lose their vision, that's bad. If they suddenly have chest pain, shortness of breath, that's bad. If they suddenly have any of the stroke symptoms, that's bad. Every patient with diabetes should also have a set of allied healthcare services. And there is currently a program that GPs very commonly use for a chronic disease management plan. And this allows them access to these allied healthcare services. This includes podiatrists, ophthalmologists, nephrologists, diabetic nurse educators, dietitians. So again, really, really good. And really, these are some excellent and really essential people that you need to get on board. And then you can go ahead and talk about drugs and other management things. So then the question again is, well, Karan, you talked about lifestyle changes, but when do you actually start them on medications? Well, you need to know the target, and the target guide is usually our HbA1c level. Our treatment target is less than 7, right? If the patient has an HbA1c between 7 and 7.5, and your patient is highly motivated, you think that they can make lifestyle changes, you might just push lifestyle and diet changes to begin with and review them at 3 months and go from there. You don't have to start them on medications just yet. If their HbA1c is between 7.5 and 8.5, this is when you'd usually start them on one medication, and at the same point, still push that SNAP-W and review them in 3 months. However, if they have really bad disease at presentation, so an HbA1c greater than 8.5, you would like to start them on metformin, which is the first agent we almost always put all patients on, and then add one more agent. Now, what agent to add is a very, very complex kind of choice to make. And there are often very little guidelines on what's actually to be used. But on the next slide, we have a table summarizing all you should know about medications. And as you may be thinking, the next the next question is, which agent do we use? As I've mentioned just 3 here, and there are a lot more. So you need to know the pros, the cons, and the side effects of each diabetic medication. So here is kind of a very basic summary that I think was really useful to me when I was going through this list. Starting with biguanides, which is the drug class, and that's metformin. They're pretty good. They are good for hypos and good for weight loss. However, you cannot use them in end-stage renal disease, and they can cause GI upset. One side effect that all patients should be aware of is lactic acidosis, as well as B12 deficiency. Lactic acidosis is probably going to be more acute and higher up on your list. Now, traditionally, once we give them biguanidines or metformin, we have about 1, 2, 3, 4 drug classes before we move on to insulin. And historically, this has been the order. So historically, we've started on sulfonylureas, then DPP-4s, then SGLT2s, and GLP-1s, and then insulin. Now, how do we change that, or what do we do differently? So sulfonylureas are a very old class of medication. They're good, they're cheap, but the bad thing about them is that they cause weight gain, and we should not be using this in end-stage renal disease. Another class of medication that's actually been really, really useful. So I'll also talk about very briefly how each medication works. So metformin works by attacking the insulin resistance side of things and allowing more efficacious use at the receptors. Sulfonylureas increase the level of insulin themselves, and therefore puts you at a high risk of hypoglycemic episodes, as you can imagine. Also, because the more insulin you have, the more glucose is going to be going in, and that can cause weight gain. DPP-4s. Now, DPP-4s are a new class of medication. Again, hypos unlikely, no association with weight gain, but cannot be given to patients with congestive cardiac failure or if they have a history of pancreatitis. So that's one thing to consider. And the suffix is gliptin. Now, one of the best new medications in the diabetic sphere is SGLT2 inhibitors. Now, they are excellent for actual hypoglycemic control. They are good for hypos. They cause weight loss. They slow down renal disease, which is really good because it's one of the main complications we worry about. And the small side effect that they do have is the risk of UTIs and DKAs. Now, how does that happen? So the way SGLT2 inhibitors work is that they increase the excretion of glucose in the urine, right? And that's how they bring down the glucose level in the blood. Because you now have urine that's rich in glucose, that is, again, going to put you at risk of UTIs. And that's the primary reason I've seen these medications being stopped in general practice. And they also have a risk of diabetic ketoacidosis, which is important to tell patients about. And this is actually a fact that we were assessed on in our exams. And the suffix is gliflozin. The way I like to think about it is that these medications work by changing glucose in the urine, and urine flows. So you have gliflozin. I know that's probably a bad way to explain that. And then we have GLP-1 agonists, which are exenatide and dulaglutide. They're, again, really good for weight loss. Hypos unlikely, and the association with thyroid cancer is a bit in the air at the moment, but we try to avoid them. And cautious use in end-stage renal disease. Again, risk factor to be aware of is pancreatitis, just like the DPP-4s. Now, some important points about this. In my GP, and what's being done in Australia, at least for most of it, is you start them on metformin. If they can tolerate SGLT2s, we start them on SGLT2s second line. After that, it is fair game to start them on either sulfonylureas or DPP4s, depending on what their side effects are. Then GLP-1s, because GLP-1s are injectables, and injectables are sometimes hard to use. And then if all else fails, we start them on insulin. So insulin is obviously great, good response, can cause hypoglycemic episodes, causes weight gain. So that's important to know. I hope that made sense. Now, a very common presentation of type 1 is again DKA. So how do we treat DKA? Now, this is a very high yield topic for fourth year when you'd be going through pediatrics. But for your year level, I think knowing the SPIDER acronym is really good. So firstly, the criteria for DKA is first you need to be acidotic. So that's a pH less than 7.3. You need to have some evidence of ketosis, which is either going to be high levels of ketones in the blood or ketones picked up on urinalysis through a urine dipstick. You also need to have a bicarb that's less than 15, and that indicates a high anion gap metabolic acidosis or HAGMA, as well as hyperglycemia, because because type 1 diabetes presents with hyperglycemic DKA. Euglycemic or normoglycemic DKA actually can happen, and that's particularly important with SGLT2s. So in SGLT2s, as I said, one of the side effects is DKA, and the type of DKA seen with SGLT2s is mostly euglycemic. Going back to our treatment acronym, so we start them off with saline, 1 liter in 30 minutes, potassium, insulin, dextrose, electrolytes, and then reassess them very regularly. Now, why do we give each one of these? So saline, because most of them would be dehydrated. Why do we give potassium? Well, we give them potassium because the way potassium is regulated in the cells is very, very closely linked to glucose and insulin. Well, Karan, how does that happen? Glad you asked. So as you know, most of your potassium should be intracellular, and normally that's linked to a sodium, glucose potassium pump, which is controlled by insulin. Now, when you don't have insulin, you have high levels of potassium in the blood, but not in the cells, because you don't have insulin to push it into the cells. Well, Karan, why are we giving them potassium? Well, because the mainstay of treatment is to start them on insulin. So when we start them on insulin, their potassium is going to very quickly shift from outside the cells to inside the cells, or from the blood into the cells. And that puts them at a very high risk of hypokalemia, or low levels in the blood. And that is going to put you at a high risk of arrhythmias. The one exception to that rule is if the only case you would not start them on potassium or start them on a lower level is if they had hyperkalemia to begin with, because then we expect that hyperkalemia to shift into a normal level with insulin. Why are we giving them dextrose too? Now, dextrose is often started later in the process, once we have that level down, and that's predominantly so we don't crash them into a hypo. Because we're giving them insulin, there's a very reasonable risk of us giving too much, or not giving too much, but seeing a rapid shift in the glucose level. So we don't want to push them into a hypo, and we start slowly giving dextrose as the glucose level comes down. Electrolytes, obviously, if they have any abnormalities, and then reassess them very regularly. So that's what I've talked about. So just a bit more information if you'd like to have a read. So start them on 0.9% saline, and we give them 1 liter in 30 minutes. And we also give rapid acting insulin 1.1 unit per kg per hour. Once the BSL is below 12, we drop the insulin rate because we don't want to push them into a hypo, and we add 5% dextrose. So this is again all to prevent that hypoglycemia. Give them potassium chloride if the potassium is less than 3.5, and 3.5 is that threshold for hyperkalemia. Anything above 3.5 is considered hyperkalemic, and therefore, as long as they are not hyperkalemic, we give them potassium. And then we want to assess them regularly with VBGs, because that's going to give us an idea of their acidotic status, their BSL, their BP, as well as urine ketones every hour. And then we always want to ask ourselves, is there a trigger to this episode? So things like infections, poor compliance, physical exertion, and so on. So patient education is really, really, really important. And during my pediatric rotation, I did see a few cases of DKA. And the most important thing that they talk about is we'll keep you in hospital for a few days, not because you need to stay, but so we can give you some education, get you in touch with a diabetic nurse educator, talk about administration of insulin, especially if that's their first episode. And that is the end of a very long lecture. Thank you all for tuning in. As always, any questions, please feel free to shoot me a message or just shoot me. It's a long year ahead. But yes, this is really a big topic. So don't worry if you can't wrap your head around it to begin with. It will make sense eventually. As you learn more and as you see more, things fit in. And as always, please look after yourself and please look after your loved ones.